In this video, let's discuss the treatment of community acquired pneumonia. But before that, we need to decide whether we'll be treating the patient as an outpatient or we'll be admitting them and treating as an inpatient. And to stratify that, we'll be using Pneumonia Severity Index score, PSI score, and it is more detailed and recommended over CURB 65. Earlier we are using CURB 65, now it is outdated and we are using PSI score because it is very detailed and includes lot of patient factors like patient demographics, underlying comorbid conditions, physical examination findings, lab findings, vitals, radiological findings. It includes all of this and it's a two-step process. In the first step, if they have any risk factors, they automatically go into step 2. In the step 2, they'll be assigned a score and by the end they'll get a final score, and based on the final score they fall into one of the 5 classes. If they fall into class 1 and class 2, they will be treated as an outpatient. In class 3, if they fall into class 3, it's a grey area. They can be either treated as an outpatient or as an inpatient based upon their patient's home environment factors and other factors. And class 4 and class 5 are definitely treated as an inpatient. So this is about PSI score and how you decide how you decide whether you'll treat them as an outpatient or an inpatient. Now coming to the actual community associated pneumonia treatment. So this treatment is divided into 4 categories. In the category 1, you have healthy patients with no underlying comorbid conditions and they didn't have an antibiotic use in the past 3 months and have very low risk for MRSA or drug resistant staph pneumonia. These kind of patients fall into category 1 and they are treated in outpatient setting. So for these patients, you will be giving amoxicillin, a penicillin, and if they are allergic to that, you can give doxycycline, a tetracycline. So these both are short-year recommendations. But if the local resistance of staph pneumonia is less than 25%, you can be using a macrolide antibiotic. But the first two, amoxicillin or doxycycline, these are short-year recommendations. Now coming to the category 2. So category 2, here it includes the patients with comorbid conditions or anyone who have used antibiotics in the past 3 months. So here these patients are also treated in outpatient basis, but you have to remember that you should be giving antibiotics that have broader coverage in this outpatient treatment. So broader coverage. When you think of broader coverage, if you're giving beta-lactams alone, beta-lactams are penicillins and cephalosporins. If you give beta-lactams alone, their mechanism of action is cell wall synthesis inhibition. It acts perfectly on gram-positive organisms. What about the gram-negative organisms and atypical organisms? Beta-lactams are not much effective. So to kill these atypicals and gram-negative, you need to give a protein synthesis inhibitor, which might be tetracycline like doxycycline or a macrolide azithromycin. They both are protein synthesis inhibitor. So you give the patients a beta-lactam antibiotic plus a protein synthesis inhibitor, either a macrolide or a tetracycline, that is doxycycline. So you can do that, or you can give a single antibiotic, respiratory fluoroquinols. It inhibits the DNA replication of those bacteria and it is effective against all organisms, gram-positive, gram-negative, atypical organisms. You can either give the combination, the beta-lactam plus a protein synthesis inhibitor, or you can simply give respiratory fluoroquinols, which inhibits the DNA synthesis of the bacteria and kill, and it is a broader coverage. You can give that. Here I want to mention a 2016 statement that is given by the FDA 2016 statement about fluoroquinols. They gave it. They asked us to limit the use of fluoroquinols in less severe conditions because of their risks. The risks are the tendinitis and tendon rupture. They said you can use the fluoroquinols in very severe conditions when their benefits outweigh the risk. You can use them there, but in less severe conditions, it's better to stick with penicillin and protein synthesis inhibitor combination. That is what they were suggesting, to limit the use of respiratory fluoroquinols. So that's about it. And now coming to the category 3. In the category 3, you have non-severe inpatients here. So here you will be using the same treatment that you used in the category 2, but probably in an IV form. The same treatment probably in an IV form. That's category 3. And category 4 are severe inpatients or patients admitted in the ICU. They'll come under category 4. In this it's in this you have to give a dual therapy. That means you have to give a beta lactam with the macrolide or a beta lactam with the respiratory fluoroquinol. Till now we saw in the second class in the category 3 and category 2 and 3 we saw respiratory fluoroquinons given alone, but here you are giving that in combination with beta lactam antibiotic. So that's about it. But what if they're having penicillin allergy? If they're having penicillin allergy, you can give this respiratory fluoroquinols with azotinib. Okay, so that is that is it. And based upon the blood culture results and urine culture results and everything, you can throw in lot of antibiotics, whichever works for the patient. And that is about the treatment of community acquired pneumonia. I hope it covered your basics, and thank you so much for watching.